Mary's always been there for me. So anyway, I introduced Mary because Mary is going to be taking over and introducing our fabulous speakers for this session. So that's a little backstory on Mary, and Mary, you can take it away.
Hi, thank you, Nate. Man, I'm getting emotional. This space is just very emotional. Thank you so much for having me. Thank you for bringing me along on this journey you're taking and including me in this space. I'm super grateful to be here and to listen to these stories from these people that I wouldn't have a chance to otherwise. It really means a lot. I didn't really know what to expect out of today's event, but it has just blown me out of the water. And all of the speakers have really touched me. Yeah, so and happy Pride, everyone. And yeah, so I'm super happy to be here, and I'm really excited to hear from everyone else. Welcome to session two. Our first speaker is their name is Courtney Felle. They're an MA PhD student at Ohio State University. And yeah, Courtney, take it away.
Thank you so much, Mary and Nate, and like everybody for being here and sharing such great stuff. I am going to try to share my screen. Let's see if I am good enough with tech to do this. I'm trying to figure out where. Here we go. Okay, let's try this. Tech is not my forte. This is why I'm in a humanities PhD.
Is this something that I should be? Oh, you got it.
There we go.
You got it.
I eventually figured it out, I say, after having run a program where I had to share screen a lot. Skills come and go. Um, okay, so yeah, thank you, Mary, for the intro. I'm Courtney. I'm going to talk today specifically about my intersex variation and intersex variations overall, and give some policy suggestions and also just kind of like some info and some personal stories. It'll be a mix. So first and foremost, this is me. A little bit of backstory is you can see me at this picture in the lower left corner. I was at a fourth grade birthday party. Anyone who knows about rare disease can pretty immediately tell I have EDS from looking at this photo. You would have saved my doctors like years of dismissal. And when I was little, I didn't yet know that I was chronically ill, but I knew something was a little funky. There were like signs that I was a little off, but I thought that's just like how I was as a person. When I was around 13 in eighth grade, I started experiencing a lot more weird symptoms. I started to have a lot more chronic pain, especially in my neck and shoulders, a lot of muscle weakness, and just really consistent, like, irregularity of my body. Like I would pass out randomly, weird things would happen. So as I started to get older, I started seeing a neurologist first. You can see me hooked up here for an EEG. I was trying to make it fun. My mom took this photo of me because I was like, I'm missing school, yeehaw. Um, all of those tests kept coming back normal. Folks didn't really seem to know what it was that I was experiencing. There was just this constant level of like, you're having some symptoms. It might be normal for a girl going through puberty to have chronic pain. It might just go away. Plot twist, guys, it did not go away. A lot of dismissal along the way, a lot of misdiagnoses. And because of that, I came to identify pretty strongly with the chronic illness and cross disability community rather than a specific form of rare disease. This picture down here, I'm in the back on the left. Shout out if you can find me with the pink hair. It's very small. I got really involved with the American Association of People with Disabilities. I was one of their summer interns for 2 years because of the way COVID ended up impacting that. And this was when we went to the White House for a tour. It's the very first time I have a photo of me using forearm crutches. It's like inside the White House. Just kind of a fun fact. From there, I ended up working for EveryLife, which is a rare disease org. I feel like a lot of people are familiar. Paul mentioned it earlier. You can see me and some of my coworkers at Rare Disease Week. But even then, I still wasn't diagnosed fully properly for most of my time there. I knew I had hypermobile EDS. I had a few other diagnoses and a lot more healthcare support than I had had at any time in the past, but there were still a lot of unanswered questions. So I was doing a lot of back and forth testing. I was trying to figure out a very complex medical history. I ended up getting access to whole genome sequencing, and through that, I discovered that I have an ultra rare form of a genetic mutation called POR deficiency, cytochrome P450 oxidoreductase deficiency. You will be quizzed on this. And it's technically an ultra rare form of congenital adrenal hyperplasia, which makes it an intersex variation. It leads to differences in hormones and a lot of other hormonal, adrenal, and metabolic symptoms. I want to shout out Interact too. I got very involved with them after realizing I was intersex. Huge shout out to Justin Sang in particular, who I knew at AAPD. Knowing other intersex folks before I found out I was intersex was truly fantastic. Um, that being said, I'm saying intersex. I think folks in general tend to know what this means, but if you put them on the spot and you're like, but what is that? They actually don't tend to have a great definition. So I tend to use the definition from Interact. Intersex is an umbrella term for differences in sex traits or reproductive anatomy. And there's a lot of different ways that this could show up for different people. It can involve what we typically think of first, which is differences in genitalia. It can also involve different hormone levels, different internal anatomy, and or different chromosomal structures. It can also involve primary or secondary sex traits. This is a distinction that's made by and large based on when something starts to show up in puberty and how primary doctors consider it to sex. So something like a really low voice, for example, would be like a secondary sex trait. Something like having a really prominent Adam's apple. Various different things. I get a lot of chin hair, for example. That's a thing that a lot of intersex folks have. That's actually secondary, but it's still something that might determine whether or not someone's intersex or if they're being bullied for being intersex, having differences in physical appearance or in sex. And this can also appear from birth or later in life. A lot of folks actually find out that they're intersex later when they are either struggling with infertility or later on once they're going through puberty, depending on what sort of stage of your life you're in. So a little TLDR of intersex history over time. A lot of folks were talking about how queer people have been here all along. Same with intersex folks. That being said, the history isn't super well documented because a lot of the initial documentation came when folks were brought forcibly into contact with the medical system. Then we have access to those records. So a lot of times when you look back and you find earlier intersex history, it's kind of just accidental that it got written down. Like someone wrote down like an oral history of someone in their town, or there's like a weird legal marriage record somewhere. Because that record keeping wasn't as normalized. Bodies were just bodies. And as modern medicine really started to cement itself, that's when you start to see a lot more intersex history of people coming into contact with the medical system and being in some ways forcibly designated toward one sex or another. By the mid 1900s, especially in the United States, you start to see this assumption that intersex people have a true sex and doctors just need to figure out what it is and then enforce it. That you're going to say it with me, is not good. Fuck John Money. We all say that together. And this is where you really start to see the modern practice of intersex genital mutilation, or IGM. These are non-consensual surgeries as early in childhood as possible that are typically corrective to folks' genitalia, but could also be either internal or external. There are a lot of different ways this shows up. As we'll talk about, folks tend to have a lot of medical trauma from this. And so the modern intersex advocacy movement actually developed in the 90s with the initial demand for physicians to end IGM practices. There's some other demands and intersex policies that have expanded since, and I'll also highlight some of those. So quick TLDR on like intersex identity and rare disease. I find it really interesting sometimes that I talk about rare disease intersex folks and they don't always know what's going on. And I talk about intersex variations to rare disease folks and they don't always know what's going on. And there's actually a lot of similarities between the two communities. The main ones that I really notice are in statistics and then in medical dismissal. There's not one clear way to define intersex for data collection. I just had to explain for you like a, lovely little diagram of what counts as intersex and what that spectrum is like. The data isn't always clear. For example, some folks who have polycystic ovarian syndrome in a way that shows up with like visibly different secondary sex characteristics sometimes consider themselves intersex. A lot of folks with PCOS do not consider themselves intersex. So how do you describe something like that in data collection? Same thing with other conditions. Something like congenital adrenal hyperplasia. There are multiple different forms. There's my ultra rare form, there's other ultra rare forms, there's the classic version, and there's the non-classic version. And people with different versions may sometimes identify as intersex and may sometimes not. So you, again, start to run into that issue. There's also the fact that you don't always know who's intersex because of like variable access to diagnostic technology. Getting whole genome sequencing is expensive and prohibitive for like 95% of the world's population. And if POR deficiency is only diagnosable through WGS right now, you are going to have a ton of people in the world who potentially have this condition that are just never going to know, never going to be diagnosed because they don't have access to that diagnostic technology. So you're trying to estimate how many people might have this condition if you're really doing the data breakdown, and that's really hard to know. And then, of course, you want to ensure equitable and comprehensive data collection. So it's also the fact that even in the States, there's a lot of people who are dismissed from a doctor's office outright and are never able to actually access this care and are never recorded in those statistics. Same thing as, oh, it decided to do something funky. I didn't like that. This is proof I don't know how to use tech, guys. Okay. And on that note of medical dismissal, that's something I also see and talk about a lot with other intersex folks. There's a lot of provider stigma against intersex bodies. Shout out to my pediatrician when I was 15 telling me that my chronic illness might go away if I just got a boyfriend and calm down a little bit about trying so hard in school. That was definitely not a great thing to say. Also extra funny because I was already out as queer by then. But you see a lot of that stigma with like intersex folks who were diagnosed at birth in particular. A lot of the normalization that folks are forced to undergo is also about rehabilitating them towards cis heterosexual marriage. So like I talk to intersex people on the daily who are like, when I had corrective surgeries from doctors, they like forced me to dilate so I could have like normal sex with my husband someday. And that is a really fucked up thing to tell a 12-year-old. That is just like a really messed up thing to tell anyone. A lot of those people were queer. A lot of those people might not have been queer, but were essentially queered by their experiences with the medical system, treating them as if they were abnormal in a certain way. And that can lead to a lot of delayed care and potential complications for intersex patients. There's a study from the Center for American Progress that 3 out of 5 intersex people have delayed necessary medical care because they do not want to come back into contact with the medical system for whatever reason. And that is really scary. A lot of those surgeries can lead to like physical or psychological trauma. And that feels to me at least very similar to a lot of the medical gaslighting and a lot of the difficulties that rare disease patients can face in the medical system. So just kind of like the rare disease community overall, intersex variations in general aren't rare. Rare disease in general isn't rare. But almost all intersex variations themselves are rare. Intersex people like to say that we're about as common as natural redheads. It's about 1% to 2% of the world's population based on the current data that we do have available. And almost all those conditions individually are rare. And it's really interesting to talk about some of those unique dimensions. And I would really love to see people do that more. Obviously, mine is rare. Most of the ones I've mentioned are rare. Quickly want to touch on too, what about disability? Kind of similar to the rare disease community. Some people identify as disabled, many do not. And there's a bunch of different ways folks could be disabled. Some people are disabled by their intersex variation. This is true for me. The way that my form of congenital adrenal hyperplasia shows up, I have secondary periodic paralysis. Sometimes I just like literally cannot move. I might have adrenal crises. I have other symptoms that are more traditionally thought of as disability. There's some other variations that lead to disabling symptoms too. MRKH is one of them that a lot of folks would consider for themselves to be an intersex variation, and it can sometimes lead to having only one kidney or certain loss of kidney function. And it can also lead to deafness. So that might be something where you're also engaging with other forms of disability or other disability spaces. You might also have other disabilities. A ton of intersex folks are also neurodivergent. Something about not being normal and being bullied by other people makes you really think about your own brain, doesn't it? A lot of folks also might have disabilities from non-consensual medical interventions. So something like IgM can often lead to higher risk of osteoporosis or cancer down the line. You might also have chronic pain from those surgeries in a way that is disabling. And then you might just be disabled independently. Intersex people are also people. I have an intersex friend who went rock climbing once and fell and got a spinal cord injury. Like, that's just how it is. Everyone is a person. And just like with the rare disease community and disabled folks writ large, often what doctors think our quality of life is, or what would make our quality of life better, is nowhere close to what it actually is or what we actually want. So I want to talk a little bit about some of the policy implications of this. I'm a policy person at my core, as much as I think I pretend not to be. And I'm going to use congenital adrenal hyperplasia as my example, since I know the most about it personally. Newborn screening comes into play with this. Newborn screening for congenital adrenal hyperplasia actually is fairly common. It is on the recommended uniform screening panel. And the way that you test for this is mostly testing for the classic version, which can lead to life-threatening situations like adrenal crisis. Some folks have salt wasting crises that might be really significant. So I was born in New York State in 1999. They started screening for congenital adrenal hyperplasia in 2002. Which is 3 years after I was born. I was not tested for CAH at birth. And talking to my doctor about whether my ultra rare variation would have been picked up on newborn screening, we don't know. And that's not a great thing to not know, because it would have been great to know up front, right? There are a lot of these situations where accessing diagnosis and healthcare upfront can be really helpful. That being said, patient-centered care is also really, really key here. It's also the fact that a lot of intersex folks are actually luckier if they are diagnosed late, because they are not necessarily brought into contact with very forcible pediatric intervention. You might get treatment to avoid some of those salt wasting crises, but you might also face medically unnecessary and traumatic IgM. So I want to point this out here because this is complicated. Something else that's important here is that what patients and their parents want is often not actually what translates into practice at medical facilities. There's some really complicated stuff happening around the actual ways that hospital policies designate who's intersex in order to either align with or like unidentify themselves from patient-centered care standards. So a really good example of this is that there are officially like 2 or 3 hospitals in the United States that have announced that they're banning IgM. This sounds great in practice, like I'm not going to say that's not a massive deal. Like, that is a massive deal. We would love more hospitals to say that they're banning IgM and like actually do that. Lurie Hospital in Chicago is one of them. They were the first. Shout out Pigeon Pagonis for like a very long protest to get them to be the first. But after Lurie stopped like doing IgM surgeries, they reclassified congenital adrenal hyperplasia from being an intersex variation or a disorder of sexual development toward being like a potentially life-threatening pediatric condition. Internally, they like reclassified where it's situated so that they could say they're doing no intersex genital mutilation while also continuing to perform those exact same surgeries on infants with CAH, because they've just reclassified what they are calling those surgeries, despite the fact that they're the same. This makes data collection really messy, which I'll talk a little bit about. But I point that out to say some of those strategies and being really in the weeds on details matters a lot, and can matter a lot for rare disease patients too, with some of that categorization. Access to therapies is another big issue, all in the classic rare disease ways, like being able to like get a doctor to prescribe something well, discrimination, cost, coverage, everything under the sun. Something else that can really affect intersex folks is that hormone replacement therapy bans either ban the therapy that you need and significantly limit it, or they carve out certain forms of like intersex genital mutilation and therapies that people don't want. So it's like you can't get the therapies you do want, but you are still allowed to like have all this stuff happen to you that you don't want. I have to be on corticoids. As of this morning, I have access. It's only been like 12 years. I'm having a delightful day. And something like that actually technically falls under an HRT ban, depending on your state. That is life-saving for me. That is so I do not stop breathing, like in a very, very literal sense. That is an entire ongoing battle. I want to really stress here that like anything that limits access to care and to medications is an issue disproportionately for rare disease patients. Like HRT bans are themselves a rare disease policy issue. And then on the data front, there's a really clear need for preservation, protection, and transparency of data. So you really need, for example, to know what's happening at somewhere like Lurie to actually track what's going on with patients, whether places are aligning with the real standards of care that are out there, holding them accountable. You also need that data protected and anonymized. You need that data to not be able to be used for something like a registry, for gender policing, for very extreme forms of exploitation and discrimination. And you need that data to be clear about how it was collected and what the definitions of different conditions were. That is very true in rare disease right now, too. I just really want to stress that like there's a lot more that I think we can and should be doing around data that is really, really difficult to navigate. So thank you all for listening. If you want to learn more, please always feel free to message me. I kind of love to like nerd out about this. Very PhD student of me. Also, you can check in about how my corticoids are going. As of today, they're going great. I don't want to take a nap more than I want to be here, and that is a massive success. So yeah, thank you so much. It's been like so lovely to hear from people all day. I'm just like in joy to be in this space.
Thank you so much, Courtney. Your presentation was beautiful. I love
I
those
cannot
colors.
say I made those slides or the flag. Massive shout out to the Pride deck on Slides Go that had an intersex flag. That was so cute. I was like, you guys rock.
Yeah, very cute. And gosh, I needed to have Courtney speak because somehow I feel like Courtney has seen me at every stage so far. And I feel like Courtney is like the vessel that kind of elevated me from beyond Histio. So I was like, okay, not only did I find somebody who is cool and like me, but like, I just very intentional. I am very glad that you were able to speak to us today. And you, again, just so you conveyed so much and you gave us I wrote Carter's already taking notes, but I wrote all this stuff down because like you gave us so much to work with. So I'm really excited about this list because we got some thank you. You really assignment. Um, does anybody have any questions for Courtney? Um, after that lovely um informative, I learned some things myself. Talk.
I feel like it's not so much a question. It's two statements. One, thank you so much for sharing. That was incredible. And I feel like I was educated on things that I've wanted to be educated on and just haven't found like a trusted resource because, as you said very eloquently, like the data is so messed up for a lot of these things right now. And I think so my background, I work in pharma world. I always like to say I'm like trying to be on the nice side of pharma, but it gets, you have to have nice people on the other side of things in order to be able to do that. And it's just an ongoing dialogue with any of the researchers that I work with about talking to them, whether it's expanding the data that we're sending them. And it's not like we're charging them for extra data. It's just like, hey, this is really important, critical information that you should be aware of to better understand the population and just like stop only thinking about human beings as cells under a microscope. Like look beyond what that is because there's so much more that you can learn about these human beings at the end of the day. So I really appreciate you sharing because now I feel like I'm armed and equipped with more knowledge to be able to I always say the best part about my job is I get to yell at researchers all the time too. And so now I've got even more ammo to go at them with for just so many different instances on rare disease work, working with the intersex community as a whole. So thank you. It's honestly, I have I'm like beaming right now because it's so cool.
I am so, so glad. In terms of like other fast resources too, Interact made a whole bunch of pamphlets that I actually love. There's ones that are like how to talk about intersex with like your family, with providers, but I think there's one about like how to ethically do research on intersex populations. They're making a medical self-advocacy guide right now, which like if y'all saw me at YARR is like kind of sometimes my shit. Keep an eye out for that one. And then if folks just like also that you're talking to are like willing to learn more but don't know where to start, Pigeon Pagonis's memoir is really fantastic. It's called Nobody Needs to Know. And it's a really, really good starting point for just like reading about how being intersex can affect someone and like a personal case study and goes through some of their time starting off as an advocate. 10 out of 10 recommend to everyone.
Thanks. I don't know if you heard that,
Jocelyn?
but my cat said thank you too. I'm not sure if my mic picked that up, but she literally said thank you. She's on my lap. She hangs out with me all day.
She's an ally.
She Dill Pickle, street rat from the streets of New York, love her dearly. And I can tell you she's certainly an ally. This girl is she's crazy.
Jocelyn?
Oh, I just wanted to say that this presentation was like super refreshing, and a person that's been like a queer advocate for years, and intersex is though it's not my lived experience, is something that I've rallied for quite some time, because I know people live in their little boxes in their head about what it means and what it looks like. But even with the knowledge that I have, you help expand it today. So I'm really excited for that. But I just want to say, like, be encouraged. I know it's not always like a easy place to live, as advocates, kind of boots to the ground with the work that we do, especially when you talk about policy. Um, but I will say, like, this is why I'm often pissing providers off when I say that patients, caregivers, or persons living with are the real experts. I'm gonna go on mute now.
110%. Also, especially like anyone who has anything ultra rare or is diagnosed or is like undiagnosed in some way knows, like you have to know so much. I was like in the weeds of medical papers figuring out the molecular pathways of like why this was giving me periodic paralysis. Like, shout out to my current endocrinologist for being cool. But in general, the medical system is not set up for complex patients.
So true.